Hi, I'm going to touch upon what I think Starlin briefly discussed, but also a lot of what the other speakers prior to me have talked about today. And basically, it's how do you manage a population more effectively in a sort of more coordinated way. I think everyone's trying to do the same thing. Doctors, Bernanke, I think, talked about integrating nurses into the management of chronic disease. I'm going to talk about a demonstration project we're doing funded by CMS. It's an innovation grant to look at integrating clinical pharmacists into primary care and patient-centered medical homes. I think what's somewhat unique about this is they are in safety net clinics. These are low-income clinics in Los Angeles, primarily in Orange County in California, and it's treating a very high-risk population. And briefly, again, this has been touched upon before in the other speakers, so I'll just be quick. How we motivated this, I think, to CMS was to say, we spend a ton of money, and 1 in 4 Americans either has no access to health care or limited access. With the ACA, we think there'll be this great increase in the need for primary care, and unmet need will sort of be exacerbated as a result of this. Chronic disease, obviously, is the driver of most healthcare costs. 45% of the population has a chronic disease. 3/4 of all physician visits are related to that chronic disease. 4 out of 5 hospitalizations, and almost 9 out of 10 prescriptions. So clearly, how we manage chronic disease is critical to how we manage our healthcare system more effectively. And if you have access, and if you see a doctor, and all goes well, you'll get a prescription, and we know adherence is terrible. About half of all prescriptions, patients' prescribed therapies do not take a sufficient dose to have clinical benefits. And so clearly, we waste a lot of money, and this is even if the healthcare system works properly. And then sort of the final piece of this puzzle, we said, well, what about the role of pharmacists? They are very well trained, as Starlin mentioned. Typically, it's 4-year graduate program. A lot do 1 or 2 year postgraduate residency training, and they are underutilized dramatically in our healthcare system. They're much more than obviously pill counters, and we should be using them in a much more efficient and closer to licensed type role. And what motivated our proposal to CMS was, I'm a health economist, but there's a pharmacy school at USC, and we started talking with some pharmacists and said, we've been very, very successful in treating high-risk populations in inner-city clinics, and here's some data to show. So in about 1/3 of the cases, we're changing a dose, we're adding medications, a third for each of these, and in many other cases, we're substituting meds, we're ordering tests, and we don't have good evidence, and we haven't done this in a very scientific way, but we have anecdotal evidence that we're improving these folks' health. And we said, well, why don't we try and, again, model this and test this, and CMS calls it innovation. It's basically common sense of how do you treat patients in a more holistic, integrated way. And so what we've done, we had to partner with a healthcare provider. We partnered with Ultimed, they run about 40 federally qualified health clinics throughout Los Angeles and Orange County. And at each of 10 treatment clinics, we have a pharmacist, a resident, which is, again, after pharmacy, 4 years of pharmacy school, they're doing a residency, which we do to keep costs down, and then a pharmacy technician who basically can be in communication, sort of a case manager, but basically can call folks on the phone, find if there are problems, and bring them in if needed. Trying to free up the clinical pharmacist to do clinical work. Part of this also, there was a training program, so we have an online training and certification program to get sort of the community pharmacists up to speed on how would you manage a disease population. It's very different working behind the counter at a CVS than working in these high-volume, high-risk clinics. And also, we're piloting a telehealth clinical pharmacy program where for areas that don't have volume, that we could provide sort of distance clinical pharmacy services remotely. How do we identify? So again, this was funded by CMS. Their primary goal is, will you save us money? And so in order to save money, you really have to keep people out of the hospital. So our aim was, let's target very high-risk patients who we think we can save money on. And what we did is we typically just went through the electronic health records of Ultimed. We looked at people who were high-cost users in prior years, who had frequent ER or hospitalizations, or had this constellation of disease conditions that we think could be managed more effectively through clinical pharmacy services. And then the third bullet is we have what we call warm handoffs, where someone shows up at these clinics, and these are clinics that are treating 5,000 or 10,000 patients a month. They're quite big and overburdened. And typically the doctors don't have time. They're spending 5 to 15 minutes per patient. And so we have an option. The doctor basically says, here's someone with uncontrolled diabetes. I'm going to give them a prescription, but I think they should be counseled and talk to the pharmacist. And so we have warm handoffs, which I think have increasingly become a big recruitment tool for us. And then again, there's the contract pharmacy we've had to deal with. But basically, as Starling talked about, what we're doing is we're getting people as they leave the hospital. That's one other aspect of recruitment, transitional care management. Case managers call them, and we call them and say, come on in after your hospitalization. Then there's just typical MTM and disease management. There's med reconciliation and those types of standard things that should be done, but are done in person. We bring them in. A typical encounter would be, again, 20 to 40 minutes, depending if it's an initial visit versus a follow-up. Again, we go over their meds. They talk with the pharmacist about how they're doing. They may order labs and other types of chart review. And then there's often education, which we think is obviously an important component, and others have talked about the importance of trying to educate. In this population, it's primarily Hispanic. Most of the clinicians don't speak Spanish. All the pharmacists do. It's a requirement. And some of these folks don't even know they have the diseases that, clearly most know they have diabetes, some don't, but they have no idea they're hypertensive or hyperlipidemia and others. So there's a lot of education involved. The primary outcomes, there's the standard med safety and medication-related quality of care, but coming from an economist perspective, and my role as PI is I've got to justify that we save CMS money, which is a challenge. Are we keeping people out of the hospital? And about 55% of this population is managed care, so we do get their hospitalization data no matter where they go. The rest of the 45% of these folks are just using these clinics as primary care. But again, we're looking at expenditures. We're doing some work on looking at access and satisfaction on patients and physician side. So in the first 14 months, we've enrolled almost 3,500 patients, 17,000 visits. Typically, a pharmacy team of a pharmacist and a resident are seeing 14 to 22 patients per day. In year 2, we started PACE clinics, which are sort of, as Starlin would put, train wrecks, elderly train wrecks, high-risk elderly populations. And obviously, they're more complicated. We see them, they're much more longer visits. But a typical panel size of these pharmacy teams will be 350 to 650 patients. Initial results here, those who've been in the program for at least 180 days. The treatment group, I think we've seen almost a 2-point drop in hemoglobin A1C. Again, the controls, these are not perfect controls. So Ultimed runs, as I mentioned, close to 40 clinics throughout the area. We've gotten data from our 10 treatment clinics. We're trying to get data from the non-participating clinics and try and get case controls to have much better. We don't yet have those data from the other control sites, so these are controls at the treatment clinic. So they're not perfect controls, and clearly we see a drop in the control group. But I think, again, the results from the treatment group have been quite promising over the first 180 days. And it's not just changing means, it's changing the distribution. I think if you look here, the fraction, these are cumulative, the fraction or this is the at baseline, if you look at that first column, it's what fraction are, distribution of hemoglobin A1C. So at the 5th percentile in the baseline group, or I should say the median's about 9.7, and you see this type of a distribution. After 6 months, we've moved that distribution to the left, as I would see it. And again, it's important not just to hit the mean, but also, as Dr. Gabay mentioned, about hitting these higher risk populations that are really uncontrolled. And I think what's encouraging for those who've been in the program for at least 12 months, we can see that this is the distribution. So the fraction who were below 7 at baseline was 9.7. First 6 months, we got that to 24.5. And we've seen relatively modest decay between months 1 through 6 and months 7 through 12. So this is encouraging news because, again, I think as other presenters have alluded to, one issue in these types of demonstrations is, yes, you can show short-run effects. Can they persist, and do they persist after the intervention stops? Obviously, this is not just a diabetes study. We're looking at chronic disease more generally. But again, these are for the diabetic patients. We're also lowering blood pressure, which is very, very important. It's easy to do, but it's an extremely often overlooked aspect for diabetics. And if you look at the types of medication-related problems that have been identified in the first year, almost 20,000 medication-related problems were identified. A large chunk here being appropriateness and effectiveness, safety issues, poor adherence, and then some other types of issues. And if you break down that 43% where we think it's an appropriateness or an effectiveness, the most common is inadequate dosing to reach treatment goals, or treatment's not optimal for the evidence-based guidelines. And again, this has been an area of contention, and this is some of the warts of the program are what happens when pharmacists say, hey, doc, you're not doing a good job. They're working in the same clinics now. And at first, I think it was really, I think we have buy-in from senior management at Ultimed, but managing that relationship between the pharmacists and the physicians and stepping on toes in turf wars takes time and takes a commitment. And over time, I think most of the clinicians have accepted and say, this is great for my practice. Not only do I have less time that I have to spend with each patient, but I think they're being better managed, and generally the relationship has been quite favorable, but it takes work. It absolutely takes work. The most common actions made by the pharmacists, again, changing a dose or drug interval, and patient education is standard, and adding meds and discontinuing meds are also common. Adverse drug events, again, excessive dose seems to lead the list. CMS's goal, they'll talk a lot about quality, but it's all conditional on saving money. And in year one, there was are you being faithful to the intervention you described? Are you meeting your enrollment targets? And then year two, it's also, you've got to demonstrate you're saving money. And it's a tough task. And let me just outline some areas in theory. So outpatient use typically increases in the short run. You're bringing people in more regularly, and what we try and do is have the pharmacy team schedule visits that coincide with primary care visits. When are you seeing your doctor next? Why don't you come in after you see your doctor? We'll spend 30 minutes and go over your meds and see how you're doing. So the pharmacy tech is typically the case manager who reaches out and talks to the patients on an ongoing basis about how they're doing and when they're coming in next. But again, we're not going to save money, at least in the short run, we don't think, on the outpatient side. And if all goes well, we'll probably spend more on the drug side. We're going to try and increase adherence. We're adding meds. We're changing meds. But the idea is to make sure people are more adherent. And so we don't think we'll save. Matter of fact, we'll probably spend more. And so the only way we're going to save money is to keep people out of the hospital. The disappointing side is so far the rates of hospitalizations on a per 1,000 per month, let's say, is unchanged. It's not statistically different. But average length of stay has declined significantly, about 23% reduction so far, pre and post intervention for treatments relative to controls. And again, the controls aren't perfect at this point. This is encouraging, and from my perspective, when I saw hospitalization rates didn't decline, I was really nervous. The clinicians tell me it's actually quite plausible that we may not prevent people from being in the hospital, but they're going to the hospital with less severe conditions or conditions that can be treated more readily, and therefore a reduction in days is quite feasible. I hope this improves. That's what we have so far. But from an economist, and again, from CMS's perspective, it's, are you saving us money? And to be honest, we've talked to, part of our mission here is to spread this to other organizations. We've had conversations with 4 or 5 large health plans or hospital groups, and they all say, this sounds great, the data sound promising, you have to show we save money. Right? We're not going to do this until you can demonstrate, we think, in a real scientific way that we'll save money. And so it costs about $300,000 per team per clinic year to run this program. And when you throw in salaries and fringes, and so we have to reduce hospital days by about 600 a year. If you just use a ballpark, $3,000 a day per hospitalization, which may be conservative in some areas and liberal in others. But we have to really keep hospital days down in order to make this pay. And I think our likely outcome is we're going to show improved health, and we have clear clinical measures to show that already. We have patient satisfaction evidence to support it. The physicians are happier. I think we'll be lucky to show modest cost savings. And again, moderate reduction in hospitalization rate can have a big impact on savings. And I think the big question longer term is, will these results persist? Can we keep the clinical improvements over time, particularly as the intervention stops? And what we're trying to do is get follow-on funding to try and randomize folks who have done well and actually try and reach those who haven't done well, but then randomize them to different types of, whether it be lower cost telephonic or text messaging type systems or other types of interventions, and change them periodically every 3 to 6 months to see if we can engage patients longer term. And before, just to close, I think we have to put these results into context. Many new technologies and devices and labor type changes are cost effective, but very few actually save money. And I think CMS has set a bar that's very difficult to meet and something we're hoping to meet. But in prior work, also for CMS, when I was at RAND, that CMS wanted to say, will new technologies and new innovation resolve our healthcare crisis? So will Medicare not become bankrupt because new innovations are going to lower healthcare costs in the future? And so we got panels of gerontologists, oncologists, cardiovascular docs. We had 4 different domains. We had about 8 or 10 docs around the country come up and say, what were the breakthrough technologies they saw coming 10, 15, and 20 years down the road? What was the probability of their success? And what would it redo to, let's say, rates of diabetes or rates of hypertension and cardiovascular disease? And then our job was to model and project cost trends for Medicare and overall spending. And I just summarized the results here. And basically, the first one was an anti-aging compound. You may have heard resveratrol, the sort of the component of red wine, which when they feed to mice, lowers obesity and they live much longer. What happens if we had a pill that extended life expectancy by 15 years? Even that would cost CMS more money, right? Because these people live longer and they're on CMS's payroll. So again, even things that we think are unambiguously beneficial still increase healthcare spending. So this says the increase in medical spending, and these are in percent terms, are always positive, even when their cost per life year saved are very, very beneficial. So generally the government has this, maybe arbitrary metric that anything that costs $100,000 per life year saved is worth doing. So most of these interventions are worth doing from a cost effectiveness perspective, but they don't save money. But that's what the sort of the bar is in this, that we have to show that integrating pharmacists into clinical practices actually saves money, not just is cost effective. And I think one limitation on my last slide is of these cost benefit or cost effectiveness ignores other types of things that we don't measure typically: patient satisfaction, quality of life, their ability to work, let alone the impact on the clinic flow and labor savings to doctors and others in the supply chain. And again, I think one issue that we don't address and we're trying to get funding to look at is what components work. Why do we see 2 percentage point declines, let's say, in hemoglobin A1C? What components of the intervention resonate with a low-income, relatively low-educated population? Is it their diabetes knowledge is improved and their ability to self-manage it? Is it their adherence to medications? Have they changed their lifestyle, their diet? All of these things that we really don't know, we're just seeing improvements, and we'll understand better in order to target things moving more forward. And again, I think it's really important to understand what resonates with these folks if we're going to have long-term impacts on this population. And that's it.